On March 11, 2020, the World Health Organization declared a
I need an
global
update on bed
pandemic.
turnover in the ED.
Within 72
Teams
hours,
are moving as
hospital
fast as they can,
administrators
but we're
across the
seeing
United
delays from
States
environmental
were activating
services.
plans most of their staff had never seen implemented. Elective surgeries canceled, visitor policies suspended, supply chain orders accelerated, discharge protocols expedited, contingency staffing activated. They were not reacting. They were executing. This is hospital surge planning. Yeah. And it is one of the most complex operational disciplines in American healthcare. A hospital surge is any event that causes patient demand to exceed the facility's normal operational capacity. It can be sudden, a mass casualty incident, a natural disaster, a chemical exposure event, or it can build gradually. An influenza season that peaks harder than projected, a regional outbreak, a multi-week trauma surge following a major storm. In both cases, the hospital must expand beds, staff, and equipment and space faster than normal operations were designed to allow. American hospitals plan for surge using a tiered framework developed in coordination with federal emergency management guidelines. The framework has 3 levels: conventional capacity, the hospital's normal operating state, all standard beds staffed, all standard protocols in effect, normal supply levels maintained, contingency capacity, the first level of surge response. How the hospital begins stretching its existing resources: hallway beds activated, non-clinical spaces converted, staff redeployed from lower acuity areas, elective procedures canceled to free up capacity. Care quality is maintained, but delivery is altered. Crisis capacity, the maximum expansion state. The hospital is operating beyond its designed limits. Every available space is converted to patient care. Staffing ratios are adjusted beyond standard guidelines. Resource allocation decisions are made at the system level, not the individual provider level. Crisis capacity is not sustainable. It is the bridge between overwhelm and recovery. The planning begins long before any surge occurs. Every American hospital is required by accreditation standards to maintain a written emergency operations plan, a document that defines how the facility will respond to specific surge scenarios. The plan addresses 6 critical dimensions: staff, stuff, space, systems, safety, security. And each dimension has a baseline assessment and a surge expansion protocol. Staff is the most constrained resource in any surge. You can add beds, you can find space. You cannot instantly create trained clinical personnel. Hospital surge staffing plans address this through several mechanisms: recall rosters, lists of off-duty staff who can be contacted and redeployed within a defined time frame. Cross-training protocols, identifying which staff members can be redeployed to adjacent roles during a surge. A medical surgical nurse supporting an ICU nurse. A radiology technician supporting patient transport. Volunteer systems, coordination with state health departments and organizations like the Medical Reserve Corps, which maintains rosters of licensed healthcare volunteers available for deployment during declared emergencies. And mutual aid agreements with other healthcare facilities, pre-negotiated contracts that allow hospitals to share staff, equipment, and patients during regional surge events. Space expansion is the most visible element of surge response. Hospital architects design modern facilities with surge conversion in mind. Conference rooms with specific floor load ratings and electrical configurations that allow rapid conversion to patient care areas. Corridors wide enough to accommodate hospital beds on both sides while maintaining a functional pathway. Parking structures pre-wired for temporary medical unit deployment. During COVID-19, hospitals converted cafeterias, waiting rooms, chapels, and administrative offices to patient care space. Some facilities deployed field hospital tents in adjacent parking lots, structures that had been pre-identified in surge plans years before the pandemic. Stuff, equipment, and supplies represents the supply chain dimension of surge planning. A hospital's normal inventory management system is designed for predictable demand. Surge breaks predictability. And surge supply planning addresses three categories: cache inventory, strategic reserves of critical supplies maintained specifically for surge events; ventilators, PPE, IV fluids, medications, blood products, vendor agreements, pre-negotiated contracts with suppliers that guarantee priority delivery during declared emergencies; and strategic national stockpile access, the Federal Reserve of medical supplies maintained by the Department of Health and Human Services, are deployable to states and localities during declared public health emergencies. The Hospital Incident Command System, HICS, is the operational structure that activates when a hospital declares an internal emergency. HICS mirrors the Incident Command System used by fire departments and emergency management agencies, a standardized hierarchy that allows personnel from different departments and different organizations to integrate rapidly under a common command structure. At the top is the Hospital Incident Commander, typically the Chief Medical Officer or a designee, who holds authority over all surge response decisions. Below the commander are 4 section chiefs: operations, logistics, planning, finance. Each section manages a specific dimension of the surge response and reports directly to the commander. The structure eliminates the confusion of normal departmental hierarchies during an emergency. Everyone has one boss. Every decision has one owner. And every resource request flows through one channel. Patient flow management is the operational core of surge response. The fundamental challenge of a hospital surge is this: more patients are arriving than can be discharged or treated at normal rates. The solution is to accelerate flow in both directions simultaneously. On the intake side, triage protocols are adjusted to divert lower acuity patients to alternative care sites, urgent care centers, community health clinics, and telehealth platforms. On the discharge side, clinical teams conduct accelerated discharge rounds, identifying patients who can safely move to lower levels of care: skilled nursing facilities, rehabilitation centers, or home with community support. Every bed that opens is a resource recovered. Regional coordination is essential when a surge exceeds a single facility's capacity to respond. Hospital systems in the United States participate in regional healthcare coalitions, networks of hospitals, emergency medical services, public health departments, and emergency management agencies that coordinate resources across a defined geographic area. During a regional surge, the coalition activates a shared situational awareness platform, a real-time dashboard showing bed availability, ICU capacity, ventilator counts, and diversion status across every participating facility. Patients can be routed to facilities with capacity. Resources can be redistributed from hospitals with surplus to hospitals in deficit. The region functions as a single system, not a collection of competing institutions. Crisis standards of care is the most difficult concept in surge planning. When demand exceeds all available capacity, when every bed is full, every ventilator is in use, every provider is committed, the standard of care that individual patients receive must change. Crisis standards of care protocols define how scarce resources will be allocated when allocation is unavoidable. These protocols are developed by state health departments in coordination with medical ethicists, legal counsel, and community stakeholders. They remove individual clinicians from the burden of impossible decisions, replacing individual judgment with systematic criteria applied consistently across all patients. Crisis standards of care is not rationing by any other name. It is the structured application of triage at the system level, designed to save the most lives possible when saving every life is no longer an option. The lesson of COVID-19 for American hospital surge planning was not that the system failed. It was that the system was tested at a scale it had never been designed to sustain. For an extended duration, it had never been designed to anticipate. In the aftermath, hospital systems across the country revised their surge capacity frameworks, extending cash inventory timelines and deepening mutual aid networks, strengthening supply chain redundancy, and formalizing crisis standards of care protocols that had previously existed only in draft form. The system learned, and the next surge, whatever form it takes, will find a different system waiting for it. The hospital you walk into on an ordinary Tuesday is not a static facility. It is a system in continuous readiness, maintaining surge plans, running drills, negotiating mutual aid agreements, tracking regional bed availability, and preparing for a surge that may come tomorrow or may never come at all. And that the preparation is the system. If you want to understand how American healthcare operates at the infrastructure level, the systems behind the emergency rooms, the supply chains, the dispatch centers, and the crisis protocols, consider subscribing to Health Systems USA. And tell us in the comments, were you in a hospital during COVID-19 as a patient, a visitor, or a healthcare worker? What did you see?